We're going to continue lecture talking about calcium. Make sure that you check out the graphics PowerPoint and click on this link here to take a look at those videos. So hypercalcemia are going to be serum calcium levels greater than 10. This can be due to increased reabsorption of calcium from the bone, and that's when it leaves the bones due to hyperparathyroidism and sometimes malignancies. PTH excess signals release of calcium from the bones and increased absorption by the intestines and retention by the kidneys. This is common with malignancies because of bone destruction by the tumor or tumor-expressing hormone. Excessive vitamin D, antacids, and milk product intake as well. Some diuretics like thiazides and lithium interfere with excretion by the kidneys. Hypercalcemia decreases neuromuscular excitability, leading to weakness and depressed deep tension reflexes. The kidneys are unable to concentrate urine because hypercalcemia, causing sodium and water loss and increased thirst. Complications can be gastric ulcers due to increased gastric acid secretion, pancreatitis because of calcium deposits, and kidney stones related to excess calcium precipitate. Treatment is going to be IV with isotonic fluids with loop diuretics that help promote elimination of calcium, medication to prevent bone reabsorption loss, such as Reclast, Zometa, and so on. Emergency situations, they can give IV phosphate to help bind that calcium, and glucosteroids to help compete with vitamin D. And then calcitonin and phosphorus increase renal output of calcium and phosphorus. Here's another graphic for you on the two differences. Then we're going to be talking about magnesium imbalances. So the normal range for this is 1.8 to 3. Magnesium is obtained through the diet, and it's plentiful in greens, vegetables, grains, nuts, meats, and seafood. It's essential for neuromuscular transmission and cardiac function. Physiological effects of magnesium are affected by both potassium and calcium. So hypomagnesemia is going to be a range less than 1.6. This is going to be common in your critically ill patients due to deficient magnesium intake. You got to think about your patients that are malnourished. They could have excessive loss or a shift between the ICF and the ECF. There's multiple risk factors for this, including alcoholism, deficient intake, increase from GI loss. Think about your patients that have GI issues like vomiting, impaired absorption, and increased renal excretion. Medications can also cause this, like loop diuretics or thiazide, aminoglycoside, antibiotics, and cyclosporins. Be aware, too, that magnesium deficits can occur also with potassium, low potassium levels, and calcium levels. So a lot of times if you're having a hard time maintaining a patient's potassium level, you're going to check their mag and find out that they also have a low magnesium level. This causes increased neuromuscular excitability and muscle weakness, and as well as tremors. You're going to have increased neuroexcitability that contributes to seizures and mental status changes. Be aware that there could also be cardiac abnormalities, dysrhythmias, and an increased risk for digoxin toxicity and hypertension. So these patients are going to have tremors, hyperreactive reflexes, positive Chostak sign and Trousseau signs, those videos that you saw, that's tetany, paresthesia, seizures, confusion, mood swings, hallucinations, and an increased heart rate. They're going to be tachy. They'll have tachycardia. So the treatment's going to be adding magnesium to parenteral nutrition if they're malnourished. Intake in foods, you want to increase their green leafy vegetables, seafood, milk, bananas, citrus fruits, and chocolate. And then they can have oral magnesium supplements as well, or IV. So then we're going to have the high magnesium, the hypermagnesia. And that's going to be when their levels are greater than 2.6. This is less common, but it can develop from renal failure, especially if they're taking supplements, and it's typically older adults. So if they're using over-the-counter laxatives, you need to be aware of that as well, especially with patients with renal function. So think about it this way, milk of that has magnesium in it. So you want to be careful with those patients that have an increased risk of laxative use with impaired renal function. Another graphic for you. So then we're going to talk about phosphate imbalances. The normal range for this is 2.5 to 4.5, and phosphate is essential in production of ATP, and that's, of course, the fuel that supports muscle contraction and nerve cell transmission and electrolyte transport. It's vital to red blood cell formation and O2 delivery to tissues, nervous system and muscle function, metabolism of fats, carbs, and proteins, and it helps to maintain the acid-base balance. So it's ingested in diet, it's absorbed in the jejunum, and excreted by the kidneys. When intake is low, the kidneys will conserve this and vice versa. So this is inversely proportionate with calcium, so that means if the calcium levels go up, the phosphate levels go down. Regulatory mechanisms for calcium levels include parathyroid hormone, calcitonin, and vitamin D. So hypophosphatemia, or low phosphate levels, are going to be a serum level less than 2.5. The most common cause of this is a shift from the intercellular space. This can be from decreased absorption of phosphate or increased renal excretion. It's often related to treatment. Think about refeeding syndrome. That stimulates insulin release, which prompts movement of glucose and phosphate into the cell, and that depletes the ECF. Other causes can be medications like IV glucose, antacids, and the antacids are because of aluminum or magnesium binding to the phosphates, anabolic steroids, and diuretics. Alcohol also affects absorption of phosphates. You want to be aware of that when you're working with chronic alcohol use. Also respiratory alkalosis due to hyperventilation as it shifts phosphates to the ICF, stress, and burns. And then you can see some of the manifestations over there on the right. So muscle weakness, paresthesias, confusion, bone pain, joint stiffness, bleeding disorders, impaired WBC function, seizures, anorexia and dysphagia, and of course nausea and vomiting. And I want you to think about why some of these would happen. So lastly, we're going to be talking about hyperphosphatemia, and that's going to be your high phosphate levels of greater than 4.5. And this can be due to impaired excretion, excessive intake, and a shift from the ICF to the ECF. Renal failure is going to be your primary cause, phosphate enemas, excessive vitamin D with impaired renal failure, and then sepsis, chemo, and trauma. So the treatment for this is going to be elimination of intake of phosphate-rich foods. That's going to be your organ meat, your milk products, and then agents will be given to bind with the phosphate in the GI tract, such as calcium-containing antacids. And again, a nice little chart for you. And these are on a separate PowerPoint again. And this just shows the different relationships between the electrolytes. This is something that's really important to remember as you move into your nursing career, because anybody that has an imbalance with one electrolyte is likely to have an imbalance with one of the other ones. And I think I mentioned before about, let's see, this one right here. This one is notorious. So if you have troubles with potassium levels and you're treating your patient and nothing is working, you always want to make sure that you get a MAG level on them as well. So some key points to remember for the exam next week. You would want to know each one of the disorders, the causes, the manifestations, what your assessment's going to be. your priority, and then your interventions and treatments. You want to know your body systems, your relationships, that's the inverse, proportionate, and the similar one. And then going to be some math on there too, and then that's just a link to study tips there. And here's a nice little cheat sheet for you. One thing to remember about sheets like this, because I got this off the internet, is to make sure that it corresponds with the values in your book. Most of them are pretty similar, but just go through, if you print this off from the other PowerPoint, go through your book and make sure that you're updating it with the appropriate levels. That completes today's lecture on fluid and electrolytes. If you have any questions, make sure that you email me, and I will get back to you within 24 to 48 hours. Have a good week.